Welcome, everyone, to the Demystifying Private Sector Engagement in Public Purchasing Programs for Prioritizing Family Health Planning Services. I'm Marie-Renée Lajoie, and I'll be your moderator today. Without any further ado, allow me to walk you through how to adjust interpretation for this webinar this morning. For interpretation in English, please click the globe on the bottom of your screen for English interpretation. Pour l'interprétation en français, cliquez le globe en bas de l'écran pour l'interprétation simultanée en français. You can mute the speaker audio by clicking Mute Original Audio right below the menu. Vous pouvez aussi couper le son d'origine en cliquant sur Mute Original Audio. Pour toute complexité, s'il vous plaît, envoyez une note dans le question and answer box au besoin. Et nous clarifierons. For any questions, you may be prompted into our Q&A box if you need any help with interpretation. Moving us along, we have a rich panel and fireside chat discussion today. We are joined by an esteemed group of implementers and donors to really deep dive into how to foster private sector engagement and what are some key lessons learned from around the world. I will have the opportunity to introduce each one of them as we dive into the conversation. But for a brief overview, we will hear from Dr. Anne Remonte, Dr. Gimin Apostol, Dr. Vivek Sharma, Davide Debeni, and Pompey Shridhar. There is a team behind all this work, first joined by our USAID colleague, who I will turn it over in a minute, Abena Amuako, Rebecca Husband from the MPHD PSI team, as well as the team behind the Momentum Country and Global Leadership Innovation Accelerator Program, Ann Fitzer, Rajat Chaba, and Molly Bodhi. It's an honor to be here with you today. And without any further ado, Abena, over to you.
Hello, everyone. Good morning, good afternoon, and good evening from wherever you are. My name is Abena Amwaku, and I am a private sector program analyst at USAID. I'm happy to open this webinar on engaging private providers in strategic purchasing programs for family planning services. Countries throughout the world are working to achieve universal health coverage, often through public purchasing programs. And a key partner countries should consider in these efforts is the role of the private sector. The Office of Population and Reproductive Health uses a broad definition of private sector that includes for-profit entities, not-for-profit organizations, including faith-based organizations, as an opportunity to expand across family planning, reproductive health, and maximize health system and human resource capacity. Our work looks to support family planning, reproductive health access in clinics, hospitals, pharmacies, shops, and community-based outlets. Private healthcare providers of family planning services, however, often face challenges in participating in public purchasing programs. Financing programs that include both public and private provision can have complex, unclear, or inadequate ways to engage with private healthcare providers and private healthcare facilities and outlets. For USAID, it is important to address these complexities and participation in public purchasing programs through our projects. This can be addressed through pathway number 2 in USAID's new Pathways to Progress framework. Pathways to Progress for Sexual and Reproductive Health 2024 to 2030 is a forward-leaning framework that guides USAID's family planning and reproductive health programs while serving as a foundational component of USAID's commitment to prevent child and maternal deaths alongside the agency's investments in maternal and child health and nutrition, malaria, and health system strengthening. It's organized around 3 pathways. Pathway 1 includes our individuals have accurate information, skills, and ability to take action to achieve the highest attainable levels of sexual and reproductive health across their lifetimes. Pathway 2, health systems provide quality, accessible, and people-centered sexual and reproductive health care. And Pathway 3, local communities, organizations, institutions, and governments create and foster social norms and policies that support individuals to make and act on their own sexual and reproductive health decisions, free from violence, coercion, and discrimination. Momentum Private Healthcare Delivery and Momentum Country and Global Leadership are two projects in the Momentum suite of awards addressing public purchasing. Momentum Private Healthcare Delivery harnesses the potential of the private sector to deliver high quality, evidence-based maternal, newborn, and child health services, voluntary family planning, and reproductive health care. Momentum Country and Global Leadership supports governments, local partners, and initiatives at national and international levels to advance technical leadership and achieve goals around maternal, newborn, and child health, voluntary family planning, and reproductive health services. Today, you'll hear more about best practices, challenges, and key insights on how to engage family planning private health care providers in public purchasing. So I will stop here. Thank you for your time and for joining today, and I will turn it back over to Marie-Renee.
Many thanks, Abena, and thank you for joining us from the USAID Office of Population and Reproductive Health. It's a real honor to have you here with us today. Before I move us along into the discussion, I wanted to share that the recording and these materials will be shared subsequently. So fear not if you miss some of its pieces, you will have the opportunity to go back and review these materials again. In addition, we look forward to having many of your questions and comments as we walk through the conversation. Within the platform, you should be able to see a question and answer box, and we encourage you to put your questions as the discussion evolves to engage with our panelists and our presenters in the fireside chat. We will continue reminding you throughout the session, but just a quick pointer before we continue. To get us going, we wanted to share a little bit of the context of this work and some of the lessons learned that both the Momentum Private Healthcare Delivery Team and the Momentum Country and Global Leadership Team have seen over the years. Maybe I say a few words about myself. I'm Dr. Marie-Renee Bélajoie. I have the pleasure of being part of the Momentum Country and Leadership Innovation Accelerator team for several years now, and it's a real honor to present this work. I'm also an associate partner with McKinsey & Company, where I'm a leader in our global public health practice. I think if you were here today, I do not need to convince you on some of the information on this page, but we know collaboration and innovation is essential to achieving collective health goals, especially in family planning, reproductive health, maternal and child health. Progress to date has been insufficient. We know that to achieve the Sustainable Development Goals, looking ahead into 2030, significant change is needed. And we believe that the type of collaboration that we will discuss here today and the lessons learned that will be presented by our many presenters from their work with PhilHealth, PSI, MSD, UNFPA, and others illustrates exactly the type of initiatives that are needed to help achieve those goals. Moving us to the next page, it's helpful to give you a bit of a brief overview of Momentum Private Healthcare Delivery, a key partner in driving this work. As Abena mentioned, this is part of the Momentum Awards, and the Momentum Private Healthcare Delivery Team is specifically focused on the potential of private sector in mixed health system, where healthcare is offered through both the public and the private sector. It employs key approaches to improve private sector contribution, including localization, person-centered care, and private sector engagement. The landscaping we will review with you today and part of this conversation illustrates example of this work. MPHD is working in partnership with providers at thousands of health facilities around the world to deliver interventions that improve health outcomes, but also respond to private sector motivations for engagement, which is well known as an ingredient for effective private sector engagement. Promoting the need for private sector inclusion through various financing mechanisms is one of their key pillars, especially around strategic purchasing of family planning and reproductive health services and service delivery. And then finally, identifying barriers to private sector engagement in more sustainable financing initiative and co-creating solutions with public and private sector actors is also one of the important missions to unlock the private sector capacities. The other collaborator, the Momentum Country and Leadership Innovation Accelerator, if you can move us to the next page, Caroline, is a leading organization that has worked over the last 5 years building expertise and knowledge to specifically address the needs of innovators as they scale up their journey. In fact, we know today that scaling innovations in low and middle settings is often 10 years behind best practices in high-income environments. And innovators face unique challenges once they hit an inflection point of a product market fit and need to scale across countries, regions, or globally. This was exactly why the Innovation Accelerator was created, to help achieve the scale that innovators need to create the impact that is needed. Over the last 5 years, the Acceleration Innovator has engaged in more than 200 consultations across projects on family planning and reproductive health, has worked through more than 25 sessions with innovators. And one of this key collaboration has been with the Momentum Private Healthcare Delivery Team, specifically looking at private sector engagement for public purchasing program, which I'll tell you more in a minute. Before I go there, one of the key publications from the MCGL team is a suite of tools on the next page that presents ways to empower family planning and reproductive health innovation for scale. I won't go into a lot of detail here. You can find more information on a prior webinar hosted also by Momentum, and we will make sure that you can access the link. It's a series of tools that gives you a toolkit, but also lessons learned on scale-up innovation. But now back to the core of our subject, public purchasing program and private sector engagement. On the next page, you will see the genesis of this work. So in collaboration together, MPHG and MCGL reviewed more than 100 policy brief, online documents, research, interviewed 45 stakeholders in 6 different countries, and built in on more than 4 years of knowledge, each in the respective field, to create a series of outputs that have included a pain point and solution analysis, which I will briefly present to you today, and that many of our panelists and presenters today will also discuss, as many of them were at the front of delivering some of these experiences. We've built a case study on family planning private sector engagement, specifically in the Philippines, as well as lessons learned from other geographies. And we've collated this into a set of insights. We hope that this will lead to additional publications, so stay put as we continue being in touch on some of these topics. I will use the next 2-3 minutes to walk you through some of these insights to give you a flavor before I turn it to really the star of the show today, which is our panelists and presenters. So moving us to the next page, this is just to give you a brief overview of the focus countries and the type of stakeholders that have shaped some of the insights you will see today and the knowledge. Whereas the main case study was based in the Philippines, as you can see, it was based on more than 26 stakeholder interviews. And we have Dr. Ann and Dr. Gallo kindly presenting on their experience. We also leverage experience in India, where you'll see Dr. Vivek Sharma build on, as well as Pompey comment on her experience with MSD. But we also had insights from Indonesia, Kenya, Nigeria, and Ghana, which maybe some of you are based and have also learned from. Stakeholders range from a number of different organizations, from family planning providers, private sector stakeholders, NGOs, donors, but also local public health officials, local experts, and then representative from national health insurance schemes. To give you a view of some of the insights that have been generated, I think the first most important point is on the next page, is really demonstrating the journeys that country go on when they launch a public participation program for private sector providers in family planning services. The one big piece here is, you can imagine, is those journeys are likely not very linear. In fact, many countries will go through different cycles as they grow the maturity of their program. And one of the key insights that we learn from, when you start on the left-hand side, from the policy bodies and the regulatory presenting these type of programs to the providers who get ready to be able to take on these programs and launch those journeys, is that whereas initially, as you can see in the middle of these materials, a lot of the conversation is around accreditation, service inclusion, mechanisms to address private sector fragmentation, so convening and coordination. As the country matures, there will be an increasing focus on administrative readiness. How are provider ready? What can they do? But also around supply chain procurement. What needs to happen for commodities to be in place, et cetera, and what is the role of those programs to facilitate some of these elements. There's obviously the private supply procurement, if it's not from a government organizations. And then countries will go on into, working with providers to increase demand generation, and then obviously engage with patients who ultimately are the recipients of those services. And that's really where the questions will start emerging around quality, around sustainability of these programs. And obviously countries at any given point will focus on different of these aspects. Moving us to the next page, when we specifically looked at the experience of the Philippines, it was very clear, like in many other countries, that there are several pain points on these journeys that many actors are working to address. And I really hope that as part of the discussion today, we have the opportunity to hear many of the solutions that are emerging and the dedication that many of these individuals are in addressing some of these pain points. I won't go through the extensive list, and I encourage you to review some of these materials beyond, but just examples is often, as country engage, they often start in a place where there is limited contraceptive coverage, and where regulatory guidance on contracting accreditation claim procedures may not be as consistent or clear. Other example, it includes minimal understanding of accreditation processes. There's a real effort made for providers to fully understand what does it take to be part of this program, and how can this be interesting for them, but also make sure that it meets the need of the regulators. Along other pain points includes, if you look at those in purples, challenges around supplies, and how do you address forecasting and stockouts and public community access. And again, these are just examples of what was learned, and a way to think through how to structure what is needed on those journeys. When we redid this work, we learned a few key lessons learned. And I will share them from a high-level standpoint, because I think we want to hear less from me and more from others. But on the next page, you will see that there was 4 major crucial components that emerge, and I believe they will be core to their conversation today. Is one, the importance of anticipating how the pain points will evolve over time. What will be the country's maturity journey? When will accreditation be the main focus of issue resolution versus addressing quality of services, for example, or supply chain? And whereas countries often may face a variety of challenges all at once, there's a little bit of that sequencing that will happen along that journey. And that's tremendously important to anticipate and plan accordingly. So, countries are not always in a reactive mode, but really an opportunity to kind of build a dialogue with private sector providers and take along that journey. Which brings me to point number 2, which is the importance of open communication and coordination among family planning stakeholders to enable co-creation of effective solutions. And that's really typically, as many of you will see the emergence of associations convening groups of private sector provider to address some of the fragmentation. Sometimes it can be part of, memorandums of agreements for providers to come together. And I'm sure we'll hear a bit more later from our different presenters. Issue number 3 is around public purchasing program, having to adapt the overarching program principles to subnational needs and understanding, what needs to be centralized and standardized versus what needs to be curated, where there might be regional sub-differences, and where that will meaningfully impact both private sector engagement, but more importantly, patient preferences, choice, and ability to access services. And then 4, a discussion around the importance of financial incentives for private provider engagement in public purchasing programs, and how this may impact cost at a variety of level. And in fact, one of the key learnings from this work is, it's been very hard today to consolidate what are the costs that these private sector providers face, and how can these be addressed. And I know there's work globally that hopefully we'll hear from to understand what those are. I'll move us along to the last page, but the only last thing I will say, because time is already flying, is there were several lessons from around the world. And again, I encourage you to take a moment. There's a real richness of lessons learned. We have went ahead here and anchored on the framework by USAID's Ready, Set, Launch, which is a fantastic resource that helps us think through product innovation and launch. So hopefully that structuring is something many of you are familiar with, and if not, I encourage you to review. And along that framework, we've really synthesized a range of lessons that I think hopefully will serve and help many of you as you engage in these spaces. I'll stop here and move us along to our panel discussion, which is really I think, again, the star of the show. But the last final word is we are excited to continue hearing about all of the work that you do and are happy to have deeper conversation on some of these topics. You can find my contact information along with my colleagues Molly in case you want to reach out about the Innovation Accelerator or this specific work more broadly, and it'll be an honor to engage further. Moving on now to our panel presentation. So I have the honor of being joined by 3 fantastic speakers who will comment on their respective experience. So first, we will hear from Dr. Anne Remonte on the momentum. If you can go back to the prior page, I will just walk through. Thank you very much. The Momentum Private Healthcare Delivery Experience in Improving Private Sector Engagement through the PhilHealth mechanism related to universal healthcare access. 2, we will hear from Dr. Gallo on the implementation insight and perspective from PhilHealth. And 3, we will hear from Dr. Vivek Sharma on key approaches and experiences from private sector, family planning provision, and public purchasing programs. Moving us to the next page now. Let me tell you about these fantastic speakers. First, Dr. Anne Remonte is the project management team head for primary care at PhilHealth. She has more than 10 years experience in the Philippine Health Insurance Corporation. She has made tremendous contribution in several areas, notably in the research and development of benefits, including for maternity and newborn care programs. She currently leads this team, but prior was involved in the development and rollout of benefit packages that contributed to the Sustainable Development Goals, including family planning. Dr. Remonte, it's a real honor to have you with us today. She's joined by Dr. Gallo, Dr. Jimin Luis Apostol, who's a technical advisor at Tigwell Philippines and supports project on private sector engagement and sustainable financing for family planning. With support with USAID, he has also contributed to research and the piloting of innovative model for private sector contracting and network delivery of family planning services with a special focus in remote rural provinces in the Philippines. Also, a warm welcome, Dr. Gallo. And then finally, we will hear from Dr. Vivek Sharma, who's a seasoned social marketing professional with more than 25 years experience in this space. His expertise encompasses the application of total market approaches, driving innovation, behavior change, communication, and private sector engagement. He currently serves as the Chief Operating Officer at PSI India Private Limited, and in this role, he takes part in optimizing operational efficiency, driving strategic growth, and cultivating a culture of excellence within the organization. We wish him a really warm welcome as well, and also want to comment that he's going through a very strong thunderstorm in Delhi at the moment. So we really hope that his audio is as good as it can be, and if not, we'll blame the Delhi rain. But without any further ado, I'll turn it to Dr. Ramonte and each of the speakers to speak through a little bit what their organization is doing and what are some of the lessons learned along that journey. I want to remind you that you can go ahead in the Q&A and pause your question, and I will facilitate a brief Q&A session right after the presentations. So Dr. Ramonte, over to you.
Thank you, Maria Renee. So, good evening. In PhilHealth, my work in the, so next slide. I work in the Philippine Health Insurance Corporation, which is called PhilHealth. So this is the implementer of the National Health Insurance Program of the Philippines. So in PhilHealth, there are actually three main players. One are our members. So we have membership from different sectors, from urban and rural areas, whether they are poor. So all of them should be members of the National Health Insurance Program. Then, of course, our healthcare providers who provide the services for the benefit packages that we cover. We engage our providers through accreditation, which is voluntary, whether public or private, so that they can participate in the National Health Insurance Program. So once our members or our beneficiaries would need services, they would go to our accredited providers, and in turn, we pay the providers for the services they provided or they gave. 50% of our accredited providers in the hospitals are actually private. And then when we started our maternity care package, most of our accredited lying-in clinics were all private. So we have ever since we started the National Health Insurance Program, we have been engaging the private providers because our clients or our beneficiaries would come from different sectors, workers, indigent. So each, whether private or public providers would have can serve different markets. Next slide. Now let me go to the family planning benefits. So all our members are eligible, whether they are contributing on their own or whether their premium are subsidized by the government. Then we have the benefit package, most for surgical contraception, like bilateral tubal ligation. Then we also cover implants and IUD insertion. For healthcare providers, we accredit hospitals, ambulatory surgical clinics, birthing homes, standalone family planning clinics, and our primary care facilities, or what we call consulta package providers. For professionals, we accredit doctors, midwives, and nurses. Actually, the accreditation of standalone family planning clinics have a role in when there were problems in private or in public sectors providing the family planning procedures because there were legal barriers then. So we work with the Ministry of Health to start accrediting those facilities that are just providing family planning services. And then we also started when in 2014 to make available our family planning benefit in birthing homes because we, of course, our beneficiaries then would be women, and these birthing home are taking care of their health anyway. So we allow them to be to also to provide not just our delivery packages but also family planning. And then when we launched our primary care benefit, the consulta, we made sure that with available, if they have available trainings, then they can also provide family planning services and be reimbursed for it, aside from the basic primary care benefit, which is consulta. Initially, we were just accrediting doctors at the start of the National Health Insurance Program. But when we have this maternity care package. We started accrediting midwives, but since midwives are also capable of providing family planning family planning services, then we also accredit them for that services. Then because of no, we have many potential beneficiaries or for family planning, we also started to engage nurses who have trainings in maternity care and family planning to be our providers for maternity care and family planning. As a requirement, we they are aligned with the rules and regulations now in the Philippines. So for the facilities, they should be licensed, or if not, for our family planning clinics, they should be certified by the Ministry of Health. Then for the professionals, we require them to have license and necessary trainings. So next slide. Now, what are our lessons or our realizations over the years? We have to engage our private providers even at the start of our development of policies. Since in the Philippines, we private sectors are already accredited anyway with our maternity care package. Then when we develop our family planning packages, we also have a way of engaging them, no, and consult them as we develop these policies. Then we also have to engage different types of facilities and professionals as may be allowed by regulation to increase the access of our beneficiaries to family planning services. And then we have to simplify the process of accreditation as well as claims filing, because this has been, as mentioned in the study by Momentum, this has been a constant problem, especially with the newly accredited or newly engaged private providers. We have to make them understand the process of accreditation and claims filing. We have to align our thinking on what we mean when we say it's simple, because we thought it's simple, but when we ask them, for them, it's not simple or it's complicated. Then benefit rates matter. We have to set our rates that is enough for them to cover the cost. And, for some are really private and they have to earn income from providing the services. So we have to set a competitive rates with our benefits. That's why, when we start, even in the policy benefit development rate setting, we have to engage the private sector so that we can set a more realistic rate across different types of providers. Then it makes sense to combine, when we engage them, to combine their engagement as providers of other benefits, because in some areas, providing family planning services alone may not be enough. No, the reimbursement, the payment may not be enough because there are fewer clients. So it makes sense that we also allow them to be accredited for maternity care, for some as ambulatory surgical clinics. In fact, we even have a provider that started as family planning provider, but now they are also provider of our outpatient HIV/AIDS. Anyway, they are catering to women and at-risk population. So they can provide these services and still be reimbursed for another package. And that helps in their sustainability. And now they're also a provider of our primary care package. So we have to simplify our process of accreditation such that if they are capable, they can provide or they can be accredited and provide for these services. Then, since most of these providers are just small, they are operating on a small scale or medium scale operation, we have to make timely payments. It has been an issue when some of our payments were delayed, then it can affect their operation. So we have to make our payments timely so that their operations will not be impeded. Then as to the monitoring We also include them in our overall healthcare provider performance assessment system, because even if they are private and they are like just a small clinic, they have to provide quality services. Eventually, we have to serve our beneficiaries, no, and ensure that they really receive quality services. So we include them in our monitoring of performance. Then the last lesson would be, we always have to communicate with them. Not only with them, but also with our people in the region who are involved in face-to-face visit, monitoring, and even accreditation and payment of claims. Because just a simple misunderstanding might hamper the accreditation, the payment, and of course, our relationship and engagement with these private providers. So those are the lessons learned in the Philippines. Thank you.
Thank you very much, Doc Ann. This was a really rich, both context setting and very nice high-level overview of some of the lessons along the way. Greatly appreciate it. Would turn it over to Dr. Gello to share his expertise from ThinkWell. Over to you, Dr. Gello.
Thank you very much. In behalf of my colleagues and team members from ThinkWell and our local partners in the Philippines, I'm very happy to be presenting some implementation insights from our 5-year project of enhancing private sector engagement in the delivery of FP services within mixed service delivery networks in the Philippines. This project is funded by USAID through the Momentum Private Healthcare Delivery Project, or MPHD. Next slide, please. And let me begin with a bit of a local context. In the Philippines, we have seen some progressive increase in the use of modern contraceptives. But as you can see here, method mix in the Philippines remains imbalanced with a preference for short-acting methods like pills and injectables. Inversely, utilization of long-acting contraceptives such as implants and IUDs remain low, despite the indication of increasing demands for these products and despite PhilHealth having benefit packages for these long-acting and even surgical methods. Furthermore, many of these FP services are offered by an overburdened public sector who are tasked to provide, alongside FP, more than 50 other vertical programs. And often, family planning services are sidelined, especially during the height of the COVID-19 pandemic. Next slide, please. Now, in 2019, the Philippines enacted its universal healthcare law. And one of the opportunities provided by this law is to expand the provision of essential services like FP through the private sector by engaging them in healthcare provider networks, or HCPNs. When engaged in these networks, private providers may provide essential services like FP and be reimbursed for services rendered as described by Dr. Ann earlier. But however, even before the law, private providers have already been experiencing challenges as discussed earlier by Dr. Ann. Everything from delays in payments to complex licensing and accreditation mechanisms, to even overwhelming training requirements that prevent them from being accredited in the first place. Furthermore,
my sincere apologies. Can I kindly ask that you slow down a little bit for interpretation so that everyone can keep track? Apologies to come in. Back over to you.
No worries, and thank you for the reminder. Furthermore, current policy guidance for engaging private providers in these networks remain unclear, especially during the start of the project, especially contracting mechanisms. Now, if you go to the next slide, just to provide a summary, these were the challenges that the MPHD project in the Philippines tried to address, from the unclear and prohibitive private sector contracting within these HCPNs or networks, to limited training opportunities to allow these private providers to be accredited by PhilHealth. And all of these contributing to missed potential to expand access to FP services through the private sector. Now, how did the MPHD project in the Philippines go about it? If we go to the next slide, we can see here that we leverage on human-centered design, or HCD, that first started with truly understanding the local barriers to PSE. we did an assessment of readiness and willingness of both public and private sectors to engage each other in these networks. And here we confirmed on the level of the public sector, it was really the lack of experience and capability to design and execute private sector contracts. And on the part of the private sector, it was really discouragement from the delays in payments to benefit packages or prices that do not offer good value proposition, as well as lack of training and access to commodities, many of which are high cost. Now, this here phase was also an opportunity for both sectors to reflect, for the public sector to realize that they cannot do the work by themselves to achieve UHC. They need the private sector, and engaging the private sector cannot be an afterthought. And for the private sector, it was really for them realizing that engaging in public purchasing schemes is a good opportunity to expand their business while contributing to social good. From here, we created opportunities for public and private sector to collaborate. First, we collaborated with a local organization, the Integrated Midwives Association of the Philippines, as a local implementing partner to help us facilitate these connections. We also provided opportunities for public and private sectors to keep on talking to each other and to build empathy for each of their concerns. And very critically, we created opportunities for the private providers to organize themselves as they journey into these public purchasing schemes together. This collaborative ecosystem enabled the co-creation of certain strategies and innovations for strengthening private sector engagement. One of these innovations is the creation of a memorandum of agreement between PhilHealth, the local governments managing the healthcare provider networks, and the private providers. And because this was created through co-creation, there was an opportunity to establish mechanisms wherein we can harvest win-win-win arrangements for everyone. This agreement was first a win for private providers because the agreement first allowed them to access commodities. And by accessing commodities from the public sector, that allowed them to actually earn additional income from the reimbursements that they are claiming from PhilHealth. This also allowed them to access trainings that allowed them to be accredited by PhilHealth. But this was also a win for the public sector. This allowed them first to expand the reach of their services. And at the same time, one of the requirements was to require the private providers receiving the commodities to submit their monthly reporting to the public sector or to the local governments. And I think bringing to bear as well the insights and the learnings from the here phase, from the readiness and willingness assessment, we were also able to incorporate some value propositions in this agreement. One very important value proposition, more than just the financial incentives, is the guarantee of timely payments. And because of that, we've seen a lot of private providers, just by itself, guaranteeing that they will be paid within 1 to 2 months. That was enough for them to want to be part of public purchasing schemes. But of course, engaging private providers in these networks will require that we capacitate and build their capabilities to participate effectively and seamlessly in these networks. And here we realize that it takes more than just clinical training, more than just teaching them how to insert implants or IUDs. It's also teaching them how they can work together, how they can execute seamless referrals between public and private sector, even familiarizing themselves with the reporting systems expected of them by the public sector. And one of the critical trainings that we've also provided was also on gender and addressing provider biases when it comes to providing gender competent family planning services. Because during our here phase, that was also one of our insights, that these provider biases prevented effective and equitable provision of FP services. And now, as we are moving to our 5th year, we are capacitating our local stakeholders, both public and private sectors, to sustain and continue all of these innovations by themselves. So moving on to the next slide, And I think this will be my last slide just to illustrate the accomplishments of the project. Before the project came in, there was no private provider that was trained and accredited in our two partner provinces of Antique and Guimaras. And now we have trained more than 25 providers from 12 different facilities in these two provinces. And you can see here that they are well distributed, ensuring equity in FP service delivery and provision. But more than that, we are seeing how engaging the private sector can be truly leveraged to expand access to FP services. In the case of Guimaras province, 100% of all FP services are provided by the private sector. This is a good business proposition for our participating private providers. It allows them to contribute to social good. This was also a win for the public sector because it, deloaded them from having to provide FP services and allowed them to focus on other programs. In the province of Antique, as much as 60 to 70% of these FP services are provided by the private sector in close coordination from referring public facilities. So we now have an ecosystem where public and private providers refer patients to each other and allow each other to contribute to the expansion and improvement of FP outcomes. So as you can see here, as of November 2023, we have inserted or provided services to more than 600 patients. None of them had to pay for these FP services, and this has only significantly and exponentially increased after November 2023 up until now. So that's all of my presentation. I'd like to acknowledge, next slide please, the members of our team, both from ThinkWell Global and from the ThinkWell Philippines team, and of course, with much thanks from USAID, PSI, and the Momentum Private Healthcare Delivery Project for making this possible in the province of Antique and Guimaras, and hopefully this will allow us to replicate this in other provinces in the Philippines. Thank you very much.
Thank you very much, Dr. Gello. I really particularly appreciated the journey together and the importance of co-creation along the journey, both in helping the public sector also work with their private sector colleagues and the private sector colleagues. And hopefully we can discuss a bit more. With that same idea, I really encourage all of you listening in today to put in your questions in the chat. I think we will have the opportunity for at least one or two questions for this esteemed panel. So it would be lovely to hear from some of you. And for your awareness, again, this is recorded and these materials will be shared in a subsequent follow-on. So you will have the opportunity to go back. Would welcome Dr. Vivek Sharma as we shift geographies now to share his experience as a Chief Operating Officer of PSI India Private Limited. Dr. Sharma, over to you.
Great, thank you so much. So I'm not sharing my video, bad weather. So I'm going to talk about specifically on a program on the public purchasing pertaining to very specific program which we called it Hausla Sajedari, which means courageous partnership. It was funded by BMGF and was co-designed and implemented and monitored with the one state government, which is the Uttar Pradesh. This is the one of the most populous state in India. And before I get into, I take this opportunity to thank BMGF for technical and funding support, and government of UP, means Uttar Pradesh, for their ownership, management and monitoring and financing it post we transition it to the government in 2018. So let me start with talking about what is this courageous partnership or Hausla Sajedari. So the Hausla Sajedari was a mechanism to channel public funds to private healthcare providers, enhancing access to quality family planning services. It made engaging with government simple and attractive for private healthcare providers. It provided a single window solution where all the formalities can be completed quickly. So Hausla Sajidari program effectively establish confidence and trust in the government's role in purchasing healthcare services. It positioned the government as a manager and overseer of the health system rather than thinking private sector or provider as their competitor. So before this whole Hausla Sajedari or courageous partnership mechanism, their existing public health financing mechanism, but there were lots of operational challenges before we started. So let me highlight at least three challenges, which is very pertinent here. The first one is that there existed various state government orders and guidelines on private sector engagement in healthcare, but they were often conflicted with one another. The state government had developed multiple guidance documents aimed at expanding public-private partnership. However, these guidelines were very, quite a bit and fragmented and frequently contradictory, which leads to confusion and inefficiencies. So that was the first challenge. The second one, that the whole accreditation and empanelment process were cumbersome and lacked a centralized management system. So prior to PSI intervention, the accreditation process would normally take 4 to 5 or 6 months, and with a only validity period of 1 to 2 years. Similarly, provider empanelment was inconsistent, adding further complexity to the system. That was the second. And the third challenge was that because there was a lack of centralized system to submit a reimbursement request to government to verify and approve, led to severe delays in reimbursement. So keeping all these challenges in mind, what we did, so we did couple of things. I will just quickly highlight those. The first thing what we did, that we made generally what is the exit strategy as our entry strategy. What it means that we emphasize government ownership from the start and collaborated with the public sector stakeholders to develop a detailed transition plan. And this plan outlined PSI support, handover activities, and timelines. And this helped in effectively managing all the stakeholder expectation and building trust. Second, we supported government by reviewing all these numerous guidelines and state orders that was there for private sector engagement. We identified gaps in the process, and then we recommended, which led to the recommendation of a comprehensive government order, which is a very famous order. It was GO 143, which established a unified process for private sector engagement in family planning services. The third, we recognized the need for a dedicated leadership and funding to ensure the program's sustainability. So, to address this, we advocated with the state government for the creation of the private sector purchasing cell. And this cell allowed officials to lead and manage the whole this platform of the public purchasing and secured a budget to sustain its activity. And the fourth point is also very important, is that to have a very effective collaboration between private and public sector partners, we helped in establishing a state task force. It was an apex body under the patronage of the Principal Secretary, Health and Family Welfare for the state government, and led by the Executive Director of SIFSA. SIFSA stands for State Innovations in Family Planning Services Project Agency. So this task force also included representatives from the development sector and the FOXY and the Indian Medical Association. And these task force regularly meet to review this whole platform and mechanism and address challenges and make policy recommendations. And then the fifth was that we created a web-based platform where uh, it was a centralized mechanism to streamline the processes and simplified how providers complete, submit, and track their accreditation applications, claim submissions, and service validation and reimbursement. So with all this, if I want to highlight quickly three major achievements, the one is that with this whole mechanism, it successfully doubled the number of family planning service outlets in the state offering family planning services. Prior to the whole this Hausla Sajedari or courageous partnership model, there were approximately 800 public clinics providing free services. The platform, it actually enabled around more than 1,000 private facilities to become accredited and more than 800 providers empaneled to offer and be reimbursed for the family planning services. Second, which is again critical, that the government of Uttar Pradesh purchased family planning services of around $12 million in 5 year period from the private sector. And third is that Hausla Sajidari model was honored with a National Health Innovation Award by the Ministry of Health and Family Welfare for its achievements. So these were some basic achievements, and this is how what we did. So thank you so much, and sorry for my bandwidth is very poor this time, quite a bit of rain, and over to you, Mary.
No apologies needed, Dr. Sharma. We're just very excited you're joining us amidst some of the challenges. Thank you for sharing PSI's experience and the great impact you've had in India. Time is running short on us, but would maybe love a brief answer from some of you on, I think you've both commented on engaging with ministries of health and departments of health to foster their excitement and sustain their motivation on engaging private sector providers. I think, Dr. Sharma, you mentioned some specific actions that were undertaken in India. Would love to hear maybe from one or two of you really quickly, what are ways that you've seen that work well to sustain that interest from the public sector, departments of health, ministries of health side? Maybe the doctor,
Okay.
yeah, Dr. Sharma, if you want to start, and then we can turn it to Dr. Ramonti.
Sure. Okay, so the critical point, I mean, there was a trust deficit, okay, when we started from both sides, from public and private. So that was the first thing that we dealt, that how best we can critically build this trust both ways from the public and private. So what we did from addressing the government concern, that they had a concern that maybe there could be a potentially misuse of funds by supporting. So that was overall their this thing, that the private sector may misuse the funds that we are getting into. So what we did, we said that in order to take care of that, we worked with the chief medical officer so that we can do validation. So every time around 10 to 20% of the service deliveries were audited, and that actually done by the chief medical officer, by the government official, and it created it really helped the government to build trust and ensure accountability, that okay, whatever things are happening, it is happening as planned. From the private sector, they were reluctant because they were quite a bit of past reimbursement delays by acting. So that was the issue, that reimbursement delay was quite a bit. So what we did, that we played an intermediary guarantor role. So funds were set aside in the escrow to ensure prompt payments to provider if the government failed to reimburse. That is what we did. But then this mechanism really reassured private providers, but though it was never needed because the government consistently met this reimbursement deadlines. So that was critical, that it gradually build the trust between the public and private sector. The second point, again important, is that uh, so we focused on the supply side intervention alone, but we realized it may not be suffice because often it needs to be completed by demand generation, demand side strategies. So, so what we did is that we quickly realized this, and we worked with the government that what is the best mechanism to address these gaps. In 6 to 8 districts, we pilot a idea that we can incentivize the public sector accredited social health activists to promote these empaneled and accredited private sector providers. And this innovative strategy created a mutual benefit between both the market players. And it was done for the first time in the UP government. And so that came out to be very encouraging. And yeah, and there are a couple of points I think I will hold here so we can.
No, this is really great, and thanks for bringing this to life. And it sounds like there is similar experiences. I remember Dr. Ramonte's comment on timeliness of payments and these points, which sounds like are similar experiences. Dr. Gello, over to you.
Well, in the Philippines, the Ministry of Health or Department of Health, both at the national and local levels, were deeply engaged in all of our project initiatives. So they were made part of the conversation and they were allowed to influence the conversation as well. So that one is very important, making them part of the process so that they can own the PSE process as well. Number two is really showing them proof of concept. And in the Philippines, we were quite intentional about relaying to them our reports of exponential increase in FP service delivery through private sector engagement. And sometimes you just need to show them that proof of concept to get them on board. Inevitably, many ministries of health tend to focus on the public sector first and think of private sector engagement as an afterthought. But when you make them realize that strategically involving the private sector, even at the outset, and not just as an afterthought, can produce results, that's more than enough to make them own and interested in the process. And in fact, in the Philippines, the regional DOH, being mindful of this exponential increase in FP service delivery, are strongly supportive of replicating the model in other provinces in the region. And some of the sample contracts and implementation insights that we have garnered from the MPHD project have been incorporated in a national policy for private sector engagement for the implementation of UHC. So engagement and communication, proof of concept, and really providing them the tools in terms of policies and sample contracts that they can leverage for replication in other areas.
Thank you very much, Dr. Gello. And I feel we're just scratching the surface, but given time, I will move us along. But Doc Ann, Dr. Gello, Dr. Sharma, thank you so much for sharing your perspective as leading implementers on the topic. Clearly, your experience is extremely rich, and we really appreciate the time you took today to present, but more importantly, the time you've also taken before to share some of your insights and the work you do in this space. Again, a big thank you to our panelists and these implementers working on the front lines of making these program realities. Moving us along, we have the pleasure of hearing a slightly different conversations from another group of stakeholders who are deeply engaged in also supporting private sector engagement through public purchasing programs for family planning services. And this group is donors who often look to some of these programs to, increase access, increase choice of women and patients and families in all different settings. Our goal of our informal chat here will be to discuss the role, perspectives, and the rigor that donors bring through their investments in funding private sector engagement in public purchasing programs. We will discuss at a high level, and I know time is fleeting, discussions around some of their roles and what they do. So what do their organizations do today? But also what they may have learned from other sectors' initiatives and the journeys that countries engage. Hopefully we cover all three, but if not, at least we'll have a brief informal chat on some of these topics. But before we dive into the conversation, allow me to introduce these incredible speakers to you. First, I am joined, if you can move to the next page, Caroline, by Davide De Bene, who is a health economics advisor at UNFPA Asia Pacific Regional Office. He provides technical support to the region on health economics and financing matters concerning UNFPA mandate areas. Davide has more than 20 years experience in developing and supporting economic and financial analyses around the globe. And he was previously at the World Bank, where he developed investment case, impact evaluations, and public financial analysis for maternal, nutrition, sexual, and reproductive health programs. We are also joined by Ms. Pampi Sridhar, who's the Indian Director of MSD for Mother as part of their social business innovation team. She is passionate about improving access to quality, affordable care and is a strong advocate for using financial and market-based approaches to tackle social challenges. She's a leading world thinker and actor, having created many of these outcome-based financing solutions. She was at the core of launching one of the world's first health development impact bond, and I probably should say the first, in India in partnership with USAID and UBS, helping scale quality improvement across private sector to complement the government of India's efforts on strategic pursuits for universal health coverage. And then more recently, she helped structure a mental health bond for youth launched by the government in Singapore and J&J. Would love to now turn it over to you, Davide, to comment a little bit on what your organization does and where were some of the lessons learned from the family planning, but also potentially other sectors. Davide, over to you.
Thank you, Maria Renee. Thank you for the introduction. And most importantly, thank you for having me in this important webinar. I think in the context of public purchasing programs, to simplify, I want to illustrate a couple of initiatives led by UNFPA. And I like to divide them in a sense into groups. One group of initiative working in low-income countries with weak social protection and health system, for example. And the initiative is the UNFPA Supply Partnership Programs, which is in essence a dedicated thematic fund within UNFPA, which aims to procure essential commodities and collaborating with governments and partners to bolster improving their health system. So right now, the initiative is supporting 54 countries across the globe. In this region where I'm based, we have 8 of them. We are reaching around 20 million women and girls annually in these lowest income countries. And in 2023, the fund has allocated 136 million in terms of supplies procured in their BI. In this region, the amount is 15 million. In terms of health system strengthening, in addition to the procurement of the supplies, we support governments to reach end user through the last mile assurance process, improving ELMIS system, capacity building trainings on reproductive health quantification, forecasting, prepositionings of commodities, and developing supply management policies. Connected to this initiative in the same country, set of countries, we have the Match Fund, which aims to increase the domestic resources and ensure sustainability, financial sustainability of these programs once, hopefully, the supply program will end, basically. So in a sense, it's an innovative financing mechanism which consists to match government contribution for reproductive health commodities on a 2-to-1 basis. Basically, for each dollar that the government contributes, UNFPA will match will double with $2. And to date, we have worked and supported 21 countries, and we have awarded over $27 million. But most importantly, governments were able, through this program, to leverage additional 17.7 millions in domestic resources. So this is our support is in essence strengthening health system, donating commodities. But recently, and well, not so recently, I will say, although we all know that providing commodities serve a vital purpose in this context, right? In the longer term, we need to think about the impact of these commodities in the contraceptive market, and also the importance of the private sector in the long-term sustainability of these programs, basically. For this reason, we have currently designed a new policies which allows UNFPA, which allows the governments within restrictions to sell the donated commodities provided by UNFPA. So among the reason why we're doing this is to really explore how the role of the private sector can be in this context is, and recognizing that most of the time, even in low-income countries, private sector has a very important role already. Often, the public sector services, I think Dr. Jello provided some examples, are overburdened. They are not always convenient for the client. When they're convenient, sometimes there are shortages that force client to move to private facilities. So the new policy has been tested now in a number of countries, and we aim to measure its impact in the next couple of years and to draw conclusion and get some lesson learned out of it. So this is in kind of a low-income country. In middle-income countries with a stronger health system and social protection system, we are focuses on integration of family planning services within universal coverage plans, basically. And one example is the case on the Philippines. We, with UNFPA, ADB, Think Well, by the way, we are trying to work more closely with Dr. Ann teams to make sure that the family planning services are properly costed and integrated in the so-called consulta package, and that will allow PhilHealth to cost and price appropriately the benefit rates that are charged to the beneficiaries and the one enrolled in the packages. We are also working, or we aim to work with the private sector, supporting the accreditation of those facilities, which is another issue that we have seen in the Philippines, is elsewhere, of course. Although many beneficiaries access to private facilities, a lot of these facilities are still not accredited. So UNFPA is aimed to support these clinics on delivering professional training and support the accreditations. And in essence, integrate the package, family planning in the package of essential health interventions. I think I stop here for now. This is just an overview of how we approach strategic purchasing in both low-income and middle-income countries.
Thank you very much, Davide. It's really nice to also see how it ties with some of the implementers' work and the overlap. Pompey, over to you on your experience at MSD for Mothers and your broader experience as well.
Hi, thank you, Mari. Yes, it has indeed been a very interesting discussion. So, MSD for Mothers is totally focused on reducing maternal mortality and ensuring better outcomes for mothers. However, we are focused on the private sector to complement the government and countries' goal in respective countries, in the high burden countries like India, Nigeria, Kenya, Uganda, etc. And we believe that, to ensure moms experience healthy pregnancies, one of the health system levers that we like to play around with is accreditation. And equally with training, skilling, and with, finance, so essentially innovative finance. And we've had a very interesting experience that I would like to share, and this is in Nigeria, where we have specifically worked with the local, the patent medicine vendors, PPMVs, as they are called, the proprietary patent medicine vendors, through a program called the Integrate E. And more broadly, about 30% of our portfolio is dedicated towards family planning, whereas the 70% is more around interpartum care and around, and in both places, we are kind of investing heavily on building out accreditation systems to complement government's goals, including that of universal health coverage, and to provide quality and respectful maternal care for that. The Integrate E project is led by the Society of Family Health, which seeks to expand access to a range of quality family planning services and also some select PHCs by implementing the Pharmacists Council of Nigeria's tiered accreditation system. However, when they began, I think they had a lot of challenges because this is a completely a set of private providers, and therefore very, very difficult to regulate and to work with. However, over the last 5 years now, in a most recent review of that particular program of accredited, PPMVs, over half of them say that their revenues increased by 50 to 100% since joining the accreditation program. And that says it all. And majority attribute it to the revenue growth due to malaria and family planning services. And I think this really supports the validity of access points for family planning and primary healthcare services, and also supports sustainability at the core of what's required for private sector to be integrated in public sector public health programs. So Integrate E is really pulling together public, private, and community stakeholders around a shared goal of supporting health system by offering access to a broad range of quality family planning services. And through these models, I think countries can really help strengthen strategic purchase and the delivery of healthcare for all without really having the government, investing in public health, and therefore creating fiscal space to do so. At the same time, I feel that the experiences in Asia and Africa should come together, and these are very different. However, through South-South collaboration and exchanging some of these best practices, we should be able to come up with some of the best, those exemplars that private sector can learn from, and really build out these systems and complement building of resilient health systems, which post-COVID we know will rely a lot on external funding as well as private capital being pumped in. Thank you.
Thank you very much, Pompey, and thank you for both sharing your experience, but also taking us on an additional world tour. I think this also illustrates the importance of this discussion in identifying lessons learned across geographies and how it can help shape different programs and how the different stakeholders can engage. Would love, Davide and Pompey, hear both of you on, as you engage with program, what have you seen those journey evolve? How do countries start and go on this journey over time, which we also know is not linear? But what are some insights on, sustaining the motivation, on, working along the challenges as they evolve? Any observation of what you've seen through your work, and insights that you can share?
Yeah, sure. I can go first. And I think, firstly, it is a long-term play. We need to be in it for 5 years or more, I would say, if not less. Because, market creation, evidence generation, really completing the entire loop of using evidence-based practices, implementing it, collecting evidence, feeding it back into shaping a system really requires the entire cycle to be completed. And we truly believe in a very deeply entrenched learning agenda with all our programming. And we really encourage open discussions and feedback to the evidence that we are collecting, share it in various forums. We want to fail. If we are failing, we fail fast, so that we are able to then tweak our approaches and move on. And that has really worked in most of them. And we really solicit inputs from the best practices all across, and collaboration is the key towards it. As far as private sector is concerned, I think about 5 years ago, several of us donors were trying to convince governments to also include private sector in the funding. I think that really hasn't come through. However, uh, there has been the blended finance piece that has come in, which is a combination of philanthropic capital, private capital, and government capital that has come forward to support some of these approaches in the private sector, which I think holds a great promise in infusing that additional capital that can serve the public goal.
These are both fantastic points, Pompey. Davide, anything from your side on some of the journeys you've seen over time?
Sure. I think going back to the example of the match fund, I think the match fund we've seen provide a very powerful mechanism, particularly for those countries that are already committed and investing in family planning, and there is, this political commitment to accelerate, right? But there are many countries that the allocation is still very much fluctuating, and some they're not really on the right path to sustainability. I think the global, regional economic landscape, particularly in the past recent years, didn't help. You know, the COVID, the inflationary push, the consequences of the different poly crises, that didn't help because the fiscal space has been shrinking over and over. What did work for us, I think, and this is kind of a push also for my organization, is accelerating and developing those evidence-based policy dialogues, basically, that we've seen that sometimes boost match funds. You know, the example, there's those investment cases to show that not only the health outcomes, positive impact of investing family planning, but the longer term economic returns. But we're also working more and more, building the cases for sustained public budget allocation for family planning, track and monitoring those expenditures to set the baseline to then better advocate for increase. But most importantly, and particularly in this region, Asia Pacific, where we have a lot of middle income countries, going back to what I said, working for a better integration of family planning services within the universal health coverage system. Philippines is a great example, and I'm not surprised that often in this webinar as case studies, because I think it's an opportunity not only to integrate family planning services within the national health insurance system, like PhilHealth, but also make sure that the private sector are integrated and accredited in the system as well. Because the Philippines, for example, has very high out-of-pocket expenditure. And in my opinion, one of the reasons is because there's still a lot of work to be done to accredit those many private sector that provide family planning services in the country. I think I stop here.
No, and Davide, Pompey, it's really interesting to hear you both comment on kind of the learning agenda, the monitoring impact and tracking, and then also reviewing your programs accordingly, right, to continue sustaining impact. And I think it goes along the same principles that, you know, Doc Ann and Dr. Gello and Dr. Sharma were commenting on this, human-centered design and then program iterations, and there's a real essence there on that agenda. We probably have time for only one more question before I turn it to closing remarks, but maybe a short question to both of you. What do you see as the major unlocks now for public purchasing program for family planning services going forward, specifically for private sector nations? What are those one or two things you're really excited about, if you want to give a short answer?
I really think we see a major role of professional associations, more so in India. That's on the quality accreditation program that we are running for maternal health. And possibly that may be really, a way that we can actually get private sector to strategically collaborate with the government in several countries, because we really need the voice of the private sector represented, and that can be done through professional associations. And we would love to build evidence around it and share it going forward.
Davide?
Yeah, for me, I will say it's definitely integrations, and the way I explained earlier, integration within USC system, as well integrating private sector within USC system as well. And also looking maybe, and we are learning, right? I gave an example of the new policies that we have that allow government to sell our commodities at certain conditions, but also looking at private sector more holistically. For example, UNFPA now is basically advancing the workplace access programs, which look at a private sector in a different way. Is not so much as a provider of services, but think about the big garment sectors in South Asia, right? To providing access and facilitating access to these services within the workplace, within and outside the workplace. So really we are learning how, you were talking, Renee, about the innovative way to engage also with the private sector. I believe this could be also a way to look at it.
We did get one small question in the Q&A that I will throw, and I think, I don't know if Dr. Pompey or Ms. Pompey, sorry, and Davide, one of you wants to tackle it, but how do you see the balance between profitability for private sector organization and improving social determinants of health? I don't know if one of you would love to comment briefly.
Would love to take that question. I mean, at the core of private sector growth and interest is value, and value cannot be destroyed. So we firmly believe that there is, profit, and profits are very necessary for private sector to, get go, but it should be done in consultation with the government, and rules should be set, and therefore the professional association, and like in India we work with. And I think that's definitely, alignment when we bring in the professional association, especially when it comes to social determinants of health. And equity has been a big focus, and the professional association is able to distribute their efforts towards ensuring that the approach is wider and that more members are involved in really contributing towards the broader goals across the country.
Thank you very much, Pompey, and thank you for taking time for that one last question. Pompey, Davide, thank you both for providing your perspective. The impact that your organizations are having is incredible, and it was really rich to hear about some of your thinking around the learning agenda, the evidence generation, but also the financial sustainability, the role of accreditation. Thank you very much for taking the time. This wraps up our webinar. I will turn it over to Rebecca Husband for our closing remarks. Rebecca is Deputy Director at the Momentum Private Healthcare Delivery Partnership as part of the Momentum Awards and as part of PSI. Rebecca, over to you.
Yeah, thank you so much, Marie Renee. And I just want to add my sincere thanks to our excellent panelists for their insights and allowing us to learn from their experience today. UHC is a needed but an ambitious challenge, and one of the pathways towards that can and could be strategic purchasing to really unlock the potential of the private sector in reaching those goals. FPRH services in particular are a challenge, while the private sector is a significant source of services for actors that are for profit, as we just talked about. This health area is not particularly profitable, and financial sustainability is really important. So offering public purchasing could really be a good opportunity in achieving family planning, reproductive health goals, along with UHC. But even when countries are willing and able to put the infrastructure in place, it can be difficult, as we saw. And we've seen lots of interesting ways to tackle this. It was very interesting to hear about some of the creative ways to create match funds, allowing sale of donated commodities at UNFPA, MSD for Mothers talking about South-to-South collaboration and learning from each other. Also, the importance of blended financing and the role of professional associations going forward. So I just want to say thank you again to our panelists, to our great moderator. We've really valued this cross-momentum partnership and opportunity with the Country and Global Leadership Project, and we were so pleased to be able to share this learning with you. Have a great rest of your day. Thank you.